Fair enough. All right. Oh, Deb, you put that on the desktop, right? Okay. All right. All right. Good morning. Let's go ahead and get started for our first grand rounds of the academic year. For those of you who don't know me, I'm Dan Dent. I'm the residency director here. I want to welcome all the new third-year students to their clinical rotations. This morning, we're going to hear from Dr. Deb Mueller, who's one of our faculty in the Division of Trauma and Emergency Surgery. Dr. Mueller did her undergraduate work at the University of South Carolina and then went to medical school at the Medical University of South Carolina. She then, due to an Air Force commitment, came to Wilford Hall Medical Center here in San Antonio for her residency. Went to UT Southwestern for a trauma and critical care fellowship, and then came back to join the faculty at Wilford Hall, where she worked with our residents at a time when we had a merged residency program with the Air Force. She was renowned as an outstanding teacher, even to those of us over here that didn't work directly with her. So when her Air Force time ended, we were very fortunate to be able to recruit her to join the faculty here with us, and she's continued to do great things, taking on special interests in some critical care areas such as fat embolus syndrome that we're going to hear about this morning. So thank you, Dr. Mueller.
I did that part right, so we're off to a good start. Good morning. I'm actually really happy to give this first grand rounds of the academic year. There's always great attendance for the first one of the year, and so I want to spread my message far and wide today. I've titled my talk, Fat Embolism, Occasionally There Are Zebras. I hope you learn a lot about fat embolism syndrome today, but more importantly, I hope you take some of the other message about caring for patients that are contained in the story I'm going to tell you today. When you hear hoofbeats, think of horses, not zebras. This is a medical aphorism. It's really attributed to Dr. Woodward, who is the chair of medicine at the University of Maryland. And certainly it refers to thinking of the commonplace diagnosis, because most of the patients are going to have those. Zebra is slang for an exotic medical diagnosis. However, we can't forget the zebras, because occasionally a patient is going to have one. And if we're unaware of them, we won't be able to diagnose them, and some of them have starkly different outcomes and results for the patient. When I teach you today, I'm going to try and teach you using a story. I hope it's as good as Dr. Pastana's story. He doesn't use slides, and he tells really good stories. I'm going to use a lot of pictures, but I hope I can keep you engaged. So I think it's easier to remember stories than lists of items. And in this rare disease especially, this story may help you remember. I'm going to tell you the story of a patient who's really here today and living a full and productive life, probably because of a series of coincidences that I'll highlight throughout the talk. He should be here because of our collective consciousness and awareness of the zebras. So I have no relevant financial disclosures. I do have permission from the patient to use his real name and photos that will not obscure his identity, as well as his medical data, to educate about this disease. And that's the first picture you'll see up here on the top. In an excellent state of health. He was a competitive mountain cyclist traveling over the country. He was an information technology specialist over at SAMC, and he was living a very full life. I want to thank his girlfriend at the time, fortunate for me, who was an award-winning photojournalist for the San Antonio Express-News. And as she would struggle through this story, she would do what she knew how to do best, take photos to tell the story. And so all the photos you'll see of the patient are not mine that I snapped during his course in the ICU, but that she would take and then share with me later. So here's our case. For those interns who aren't familiar with our unknown names over at University Hospital, when you come in as a trauma patient and you're hemodynamically unstable, we give you an unknown name. And humorously, they're always spelled wrong, so that's not a misspelling on my slide, Unknown George with 2 R's, and Jay would laugh about this much later. His real name is Jay Ellis. He's a 42-year-old male who, again, enjoyed cycling and had taken up motorcycling in the last few years, riding out in the hill country with a couple of his friends on those back Texas roads where it's safe. He was fully helmeted in full leather gear. He would take a turn near Tarpley, Texas with his friends, slide off the road, maybe loose gravel, he still doesn't know to this day, as he was a very safe rider, and into a signpost. He had no significant past medical history. As I said, he was the epitome of health, competitively cycling. His friends were actually familiar with tourniquets and took off one of their belts and put a tourniquet on his left lower extremity. And this is where coincidence number one will come in, and I've highlighted them all in blue. If I forget to mention some as we go through the talk, you can come up and ask me about them. Number one, who would be the first person on the scene of this accident? None other than Dr. Fred Corley, a senior orthopedic surgeon here at University Hospital who was driving his truck out to do some duck hunting and happened upon the scene of the accident, stopped, said, "Could I help you boys?" And of course they were like, "Only if you're a physician." He's like, "Well, it just happened to be." And he would actually render aid till EMS could get there. The patient would need to be moved to a field because they were on a windy road to be evacuated by AirLife. And Dr. Corley would actually call UHS, talk to the orthopedic resident on call, and let him know what was coming in. So he arrived to our trauma bay. This was a Sunday afternoon. He was hypotensive, heart rate was normal. His Glasgow Coma Scale was 15. He had lost consciousness briefly in the field, but he was alert and oriented on arrival. His physical exam was really unremarkable, except for bilateral lower extremity deformities and a lack of palpable pulses in the left, with a very clear open fracture, destructive mangled extremity on that side. He quickly went for the CT of the head, neck, chest, abdomen, pelvis, and a CTA of his left leg. Really, the only remarkable finding was on the CTA of the left leg. 2 of 3 vessels were out. The only remaining vessel to his foot was the posterior tibial artery, and it was very tortuous in its course through the fracture location. He would come back to the trauma bay, start to get all his plain films for orthopedics to plan their operative approach. On the right, he was luckier, a grade 1 open fracture with a small skin hole on the medial calf, but otherwise a pretty normal exam on that side. On the left, he would not be so lucky. He did have no motor function in the foot. The skin really posteriorly was holding on the fracture. Most of the muscles had been transected. He did have some sensation in some nerve distributions, and he had a Doppler PT signal, but nothing else. So he'd go to the OR that day, and he'd have an IM nail on the right and a spanning X fix on the left with a washout with a plan to return him the very next day. There was a high suspicion that this leg would require an amputation, but as usual, we always give it the best shot, kind of wait for things to determine. And this is a picture of him in the ICU that night with his X-fix on the left side. And he would wake up that night and follow commands. He was kept intubated mainly because he was going back to the OR the very next day. So we went back to the OR. This was a Monday, much like today. I would be covering the ER and the OR that day. He was with orthopedics up in the old building on the 12th floor, and I got a call to come make sure I agreed that probably an amputation was the best thing. And often we do that in trauma. We like 2 faculty opinions when we're taking off a young person's leg. And I agreed with them. This is really a non-salvageable extremity. He had not demonstrated any more sensation or motor function in the ICU overnight, and he had very poor flow from a vascular standpoint, as well as just really nowhere if you wanted to improve flow to cover. All of his muscles were transected. So that was performed. And I would meet his girlfriend, Lisa. I would go out to talk to her about the fact this was necessary. It was heartbreaking, I know, but he would do well with a primary amputation. She actually had done a photojournalism piece on the wounded warriors over at SAMC, so she was well aware of all the prosthetics, and she was still upset, but understood that he could have a full life with a prosthetic. In the ICU, he wouldn't wake up. Hours after his anesthetic had worn off, his GCS was 4T. A stat, head CT, and CTA of the neck were obtained and unremarkable. Neurology and cardiology consults were placed. He had an episode of SVT to the 160s. They came by, and this is the first time you see fat embolism mentioned in his chart. The neurology on their differential diagnosis note mentioned fat embolism versus a noxious injury or embolic stroke. And they recommended the MRI and the EEG, as well as a transthoracic echo to look for a patent foramen ovale. This is a picture of his MRI. The reading here in the details, T2 hyperintense foci. These are these little white spots you see on the imaging over here. These are these T2 flare images you see on the MRI, all these white areas which were really showing intense inflammation. And really in a widespread distribution, all of the arterial circulation distribution, the occipital, parietal, and frontal distributions. And then over on the to the right, you see this is diffusion-weighted imaging, and these are showing areas of restricted diffusion, typically due to edema. The impression would be bilateral subcortical infarcts from shower emboli, multiple strokes in multiple vascular territories. His family was told he would never recover. So, as usual with this, it's very difficult for a family to accept a diagnosis and a change so stark in one day. The palliative care team was engaged and they started to work with the family. Jay had been very clear about his wishes. He had had several accidents cycling, luckily never having a head injury, but multiple rib fractures, and he knew of others who had not done as well, and he never wanted to be kept alive on machines. The family began to believe he would never be the same. On the 25th, they would hold, this is Sunday, so 1 week after his accident, a meeting that lasted several hours with the family, again, asking for explanations. How did he have this stroke? Why did he have a stroke? He's a totally healthy guy. What is, it doesn't make sense. The decisions or diagnosis remained the same, and the prognosis remained very poor from everybody's opinion. He would likely be on a ventilator and require a PEG. He was made do not resuscitate in accordance with his wishes, and no escalation of care, but the family wasn't quite ready to withdraw care. So let's talk a little bit about fat embolism before I tell you more of the story. Really, fat embolism itself is just the presence of globules of fat in the lung parenchyma and peripheral circulation. And as I'll show you, this happens very often. Fat embolism syndrome is the serious manifestation of the same phenomenon. And why some patients have it and some don't, we don't understand why they develop the full-blown syndrome. It was first identified by Zenker in 1862. He was doing an autopsy on a patient who'd been crushed between two railroad cars and found fat in the vascular supply to the lung. Von Bergman, in 1873, would diagnose the first, or write about the first clinical case, a patient who had femur fracture, progressed to coma, respiratory distress, and death. So how often do you embolize your fat if you break a bone? Really often. It's kind of scary how often. They've looked at this by drawing venous samples from the bloodstream when you're having your fracture repair. If you draw it systemically, about 67% of the samples will contain fat, bone marrow fat. If you do it in the ipsilateral iliac vein of the leg that's being repaired, it's up to 90%. But this is really the most elegant study done looking at the incidence of fat emboli during certainly fracture fixation. This particular author did TEE on 24 patients with tibia or femur fractures, isolated injuries. And he would put the probe down, and what you see there on the top, try and get my arrow up there, right atrium, right ventricle, left atrium, left ventricle. So this is a normal view, the dark fluid-filled heart. And then he would keep the probe down and he would characterize the volume and the size of emboli during the cases. And he would classify them as large being greater than a centimeter, minimal kind of less than 1 to 2 millimeters, and then moderate in between. And every single patient had some fat emboli. The majority of them were this small kind. You kind of see, I lost my arrow again down here, this little snowstorm appearance that you're now seeing in the right ventricle. All of those are little pieces of bone marrow and fat escaping into the cardiac system, vascular system. And this one, this snake-like serpentine is a greater than 1 centimeter fat emboli. And what was interesting about this is he actually followed the patients to look for who developed fat embolism syndrome out of these 24 patients. And 3 out of the 4 that developed the diagnosis by the criteria we'll talk about had larger size. So size may matter with fat embolism syndrome, and those that maybe shower smaller sizes may not have the same effects. But really nobody's looked at that again, but a kind of a fascinating study that he performed. So what about the syndrome, the incidence of the full-blown syndrome? So now we know about 90% of you, if you break a bone, are going to have some fat emboli getting into your vascular system. The incidence in the literature is very wide. As you can see, the retrospective review, very low, but done at Seattle, a major trauma center up there, where they can only identify it in less than 1% over a 10-year retrospective review. I probably think the best study is the one here on the bottom by Dr. Fabian and his group, about 11%. That kind of makes sense actually with the Pell study there. His incidence was about 12% in all the patients he looked at. And we'll talk about this last study in more detail, but as you can see, anywhere from 0.9 to 23% you'll find in the literature. So in this study, they did a 1-year prospective study in patients who presented with long bone or pelvic fracture. They did physical exams and labs for 5 days, including arterial blood gases, where they would look at an AA gradient. And this will become important in Jay's case later on. They documented about 11% incidence, and 4.3% of cases were severe with a 10% mortality. And again, these patients, consented to the study. They probably had a lot more patients eligible that they couldn't get consent. Some of these patients did have pulmonary injury, and they were actually quite strict about if they couldn't ascribe your respiratory insufficiency to just fat emboli, maybe you had lung fractures and pulmonary contusion, they actually didn't diagnose you with it unless you met the criteria in another way. So I think this is probably the best study out there looking at true incidence, so about 11%. The etiology, as we talked about, the most common is going to be your long bone fractures and pelvic fractures. But fascinatingly, this has been reported with a lot of other procedures, total hips and total joints. So your patient's coming in for an elective procedure, and next thing you know, they're comatose. Severe soft tissue injury, burns, plastics procedures, liposuction, and interfering with the fat that way, bone marrow harvest, and then again, a list of non-traumatic causes on the right. So these are all kind of the litany of, there's more than this, of case reports you'll find, which is really what the majority of literature on fat embolism syndrome is different case reports of how it's seen in different situations. So the pathophysiology, two real theories have been proposed. The first being the mechanical. So as I showed you, the fat moving into the venous sinusoids that have been disrupted at the site of the injury, and then the bone marrow embolizing up to the heart. And then obviously out into the pulmonary circulation through the pulmonary arteries really explains the ARDS or respiratory insufficiency component of fat embolism syndrome, but it doesn't really account for the cerebral effects. And so in the mechanical theory, the belief is, and we know that if you do echoes on most people, up to 23% of us have patent foramen ovale, so a connection between the right atrium and left, and that the blood can escape, you can see it in that circle there, into the systemic circulation side and then embolize to the brain. And so the mechanical theory espouses that. And then also microembolism in animal models of fat embolus syndrome. If the fat particle degrades and is liquid to some degree, if it's less than about 7 microns, it can go through the pulmonary circulation and then proceed on. And then the toxic intermediary theory, which came about a little bit later, is really that it's the free fatty acids. It's not the actual fat when it embolizes. And this may explain that the symptoms sometimes are delayed, like in Jay's case. He woke up the first night, right? It was the second operation which he became comatose. But that the fat is broken down in the plasma in about 24 to 48 hours into these free fatty acids. And we know these are incredibly inflammatory. If we want to cause an ARDS model in animals to study ventilator strategy, the best way to do it, oleic acid intravenously. In seconds, you have profound ARDS, and you can try all your different ventilator maneuvers to see what will work best to oxygenate those. So they are very inflammatory in nature. And it kicks off that cascade. You start to get platelet aggregation, all your other kind of coagulopathy, and everything else that goes along with intense inflammation for a variety of disease processes that we see. It's probably obviously a combination of both of these theories, right? And they both play a role. So that's how it happens. So how do you diagnose it? Well, Alan Gerd wrote this paper again in 1970, and I'll show you another article of his next. And I want to focus on this first paragraph here. Since Zenker described the first case of fat embolism in 1862, there has never been a reliable diagnostic test for this condition. There can be no doubt one is required. The clinical picture is very variable and often missed, and all too often the diagnosis is made post-mortem. This is true today. We still have no reliable diagnostic test. It's probably why this patient had a different diagnosis in the beginning. And so it's important to remember, we make lots of progress, but sometimes with the zebras, it's much harder to move forward as it's, again, a rarer diagnosis than we think. 4 years later, he would write another paper with a partner of his, really trying to say, how do we say who has it? And they would look at 100 patients they felt had fat embolism syndrome and come up with criteria based on all the findings the patients had. And so really there's the triad, the major triad of respiratory insufficiency. Again, wasn't really defined what exactly, ARDS versus minor respiratory insufficiency. Cerebral involvement, altered mental status to coma, and a petechial rash that we'll talk about more. And that's a really key point for you young physicians in the audience. The petechial rash can be pathognomonic because it doesn't happen with all the other things. The minor criteria, they felt 4 of them were necessary, and those were mainly lab findings: elevated bilirubin, a little sign of acute kidney injury, fever, tachycardia, anemia, and thrombocytopenia. But what's difficult about those, the minor criteria, is if you look in our ICU today, probably 10 patients have a lot of the minor criteria. And so, especially after trauma, with the anemia and tachycardia and things like that. So it can still be very difficult to narrow down who has this disease. There's been another attempt to refine the criteria further by Schoenfeld. He was looking at giving prophylactic steroids to prevent fat embolism syndrome and really wanted to make sure his groups were the same. So he kind of put more numbers on things like the tachycardia greater than 120, hypoxemia with a PaO2 less than 70. So he was really doing a study and wanting to make sure he got equal groups. And so I'd say this is a nice scale as well, and both can be used. There's some others that have been proposed out there. They're really no stronger than the original criteria written by Gurdon Wilson in 1974. So back to our story. So it's a Monday, much like today. I would come to grand rounds, and I would just happen to be the faculty rounding on that side of the ICU. This other person pictured here is Nancy Satsangi. She was an MS3. And this is where coincidence number 2 would happen. I would get over there, and we have trauma morning report at 10. It's really hard to get through the ICU on a Monday. And so I would occasionally go up there after this conference, while the residents were still in conference, and find whoever was there, med students, mid-level providers, and start rounding. And I would get to the first patient, and it would be Jay Ellis. And Nancy would tell me his story. And Nancy was a really good med student. She had been there the day Jay arrived. She had followed him the entire course, and she knew his story really well. And so she presented it to me, and I kind of probed Nancy. Why did fat embolism syndrome jump into my head? Because of a story. Because of a story from my fellowship, where I would take care of a young man who had kind of driven his baggage cart at DFW a little fast and a little tight turns, maybe having a little fun out there, and rolled it, and would come in with a pelvic fracture and a long bone fracture, normal CT of the head, go to the OR, come out and floor at ARDS, to the point that I learned a lot about difficult ventilator strategies with him. We never got a CAT scan of his head because he was so unstable for days later. He would progress to cerebral edema and die. He was 22. And I would never forget that story, and that's when I really learned about fat embolism syndrome. And I just stood there outside Jay's door thinking, sounds like the same story. I mean, I've only seen it one other time, 15 years ago, but it sounds like the same story. So I probed Nancy, why don't people think he has fat embolism syndrome? We got to teach a lot. She was like, gosh, she's the only one there in the mid-level. She did a good job. And she told me that, I said, why do people think he had a stroke? This is a totally healthy guy. He's 40, like an athlete. I knew that because I'd met him a week ago, met his girlfriend a week ago in the OR, holding area. And she said, well, he had hypotension on induction of anesthesia. Well, that happens to everybody, I'll tell you that, baseline. And they think he had a stroke, watershed strokes from that hypotension. I was like, really? How low was his blood pressure? And she didn't know that, but she assured me she would have it later that day. So we talked a little bit. But at this point, everyone thought Jay was a horse. Why might that be? Well, if you just look for citations on stroke, so you Google it right now on your phone, 227 million things have been written about stroke, and in PubMed, let's narrow it down to the medical literature, 250,000. Fat embolism syndrome is truly a zebra. Today, only 1,100 citations come up on fat embolism syndrome in PubMed. So it's hard to pick out a zebra, I will tell you that. So I would go down to my office. I would be curious, and I would remember my story, and again, why I'm using a story today, because they're easier to remember, again, than list. And the just clinical scenario just sounded so similar to this patient I took care of that I would go down to my office. Nancy would be looking up a few details for me, and I would look through Jay's stuff. So this is his x-ray on admission to the left and the x-ray in the ICU to the right. I think most of us practicing critical care would say this could just be penetration. Really, it's not dramatic. And remember, the last case I saw, the ARDS component was the most dramatic. So he really didn't look like he had a respiratory component. But if you read the literature carefully on FES, a snowstorm appearance is basically what's described on the chest x-rays, which you could argue it could be that. But it's not real convincing. So then I decided, let's calculate his AA gradient. That's supposed to be one of the most sensitive indicators. And I had to look that, I had notes from this case from when I was a fellow, still in my office somewhere, believe it or not. And I got it out, I'm like, okay, yeah, AA gradient. So glad MedCalc exists today, but back in the day, we would, get out our formulas, and here's how you calculate an alveolar arterial oxygen gradient. You need the FiO2 and a blood gas and use their PaCO2 to get their alveolar, and then you have your arterial from the blood gas. And the normal kind of ballpark figure there in the middle is your age over 4 plus 4. So for Jay, that would be about 14. He was 42 at the time of this incident. And as you can see, the 18th, that's in the trauma bay because he arrived hypotensive, so they drew a blood gas on him. And 281, there's a little bit of gradient there, actually, if you calculate it out on room air, but it's not as severe. But the very next day, after he's not doing so well, 137, that would never get our attention really on rounds in the ICU. 137, that's awesome. We're worried when your PaO2 is drifting into the 60s. But if you look at his AA gradients, it's significant for someone his age on the FiO2 he was on. So he did have an AA gradient. I'm like, I don't know. So petechiae, I wouldn't do this till later in the day. I would kind of run through his chart in Sunrise a lot before I went up and started looking in his armpits. Thought it might alarm the family a little bit. So this is a picture on the left of, you can see all these black spots are petechiae. They seem to go mainly to the axillas and then to the chest wall. And this is thought to be because of the hemodynamic properties of fat in the bloodstream. You know, fat floats, right? Less dense, so it once it enters the systemic circulation, goes to, if you're in the supine position, your anterior chest and your axilla. It only happens in about 60% of the cases. But if you find it, there's no other disease process that mimics that in the right clinical situation. And so it's really the key. Physical diagnosis remains the key if you can find it. And I want to emphasize that here. They appear in 24 to 72 hours. This is a week later. I'm in my office hoping maybe there'll be petechiae, but I'm not sure. I'm going to show you this picture on the next slide that Lisa took after I told her my suspicions. And they are very faint here. Not real impressive, but there's a few, and they're on both sides, so he has a few residuals. But I'm like, I don't know, it's pretty soft. I would have loved to have seen him a week before and seen if there were more, but there were some there. There were definitely some there that were different than his skin appearance at other locations. So, on the 26th, we looked through all the criteria for Jay, and it looks like he has at least 2 major. I really didn't give him the respiratory insufficiency. I just wasn't convinced. There were other things that had gone on. He'd gotten 2.5 liters of blood when he came in for his hypotension FFP, so he could just have some edema as well from his transfusion related to his initial resuscitation. But he scored out as at least 2 major and 4 minor. So he met the Gurdon-Wilson criteria, and he also met the Schoenfeld score of 8 because of the petechiae. So I thought he had it. But what about this MRI? I mean, 2 neurologists. The family actually asked for a second opinion. He had seen the original neurologist when his mental status changed. They asked for a second opinion because they just didn't understand why he could have a stroke. And 2 neurologists have said he has watershed infarcts and he's going to die. What about an MRI? Well, the patient, remember my story, he died without an MRI. We never were able to get that. I don't even think we did that many MRIs back in that day. Well, I found this paper on the Starfield pattern, and it's considered pathognomonic in the right clinical scenario for fat embolism syndrome. And again, these are these T2 flare hyperintense dots. So you have that black sky, black night sky with the stars on top on the T2 flare images. And then the diffusion weighted below, you can also see the bright white areas. Again, these really show edema, and that can be vasogenic from disruption of the blood-brain barrier. It can be from microinfarcts and edema all around where watershed infarcts are. It can be that. It can be fat embolism syndrome. So these really show you intense inflammation in the brain and edema. And it's important we kind of learn what MRIs are telling us. We always look at the impression, but sometimes you have to dig deeper. What does it really mean? So it is consistent with watershed infarcts, but it's also consistent, according to this fellow, in the right clinical scenario with fat embolism syndrome. So I go back and look up Jay's MRI, have to find which series in all those millions of series they always have for these. But you see the little white spots, speckled spots all over the black background. And then these are the diffusion weighted images as well. I'm convinced. Can we treat it? Can we do anything? Really, no. That's kind of a sobering part of this diagnosis. Really not much you can do. The first 4 items here have been studied really in animal models of FES. The top 2 can delay free fatty acid breakdown, basically, impair lipolysis. The second two deal with that platelet aggregation you're getting in all the small vessels once your inflammatory cascade kicks off. But again, this being mostly in trauma patients who are multiply injured, the blood thinning agents haven't ever been looked at in humans well. But steroids has, again, anti-inflammatory drugs, so we'll spend a little time on that. There's been 2 meta-analyses looking at, do steroids reduce the risk of fat embolism syndrome in patients with fractures, written in the last decade. These are the odds ratio tables from those studies, and for those that might not be familiar, when you have an odds ratio chart, basically you look at this line, and to the left, that favors treatment, and to the right does not favor the treatment. And in both of these meta-analyses, steroids do decrease the incidence of fat embolism syndrome. Only 6 to 7 randomized controlled trials, very small numbers, only 389 patients total in all of these trials. They dosed methylprednisolone typically on arrival and then for the first, sometimes up to 72 hours. The doses varied significantly in these trials, but they estimated a number needed to treat of only 5 to 8. This looks really promising. Why don't we do this? Why don't we do this? Well, there's always the but, right? The data currently available does demonstrate that steroids reduce the incidence of FES, but the sample sizes are small. Some of the study quality was poor. It occurred over a wide time frame, so a lot of other changes occurred in trauma care and critical care. So not sure that the outcomes were really related to the steroids. And unfortunately, not a lot of them, the authors followed patients for long-term effects, specifically infections, given the fact that we were using steroids, and whether their fracture sites healed and there were other complications. So at this point, there's not a consensus to use steroids prophylactically, and a larger, good, well-designed randomized control trial was recommended, which hasn't occurred to this day. I will mention that there are a couple newer papers on inhaled steroids. 2 of them, they also have not reached statistical significance. They show improvement in markers such as hypoxemia. Again, the steroids aren't absorbed systemically to any significant amount, so it's hard to think it would benefit them from a cerebral component or other components. But that's kind of the latest trend, is to look at them in an inhaled fashion. Does what the orthosurgeons do make a difference? Well, we know early fixation tends to decrease all forms of pulmonary complications. They have ways to aspirate bone marrow while they're doing their procedures. Most of these studies, again, show decrease in amount of volume of fat emboli, but not necessarily those who develop the syndrome. And so there's no standard approach in the orthopedic operative world today in regards to preventing fat embolism syndrome. I thought this was a fascinating study, so I included it here. This group took some mongrel dogs and placed these microvena filters in the vein on the ipsilateral side, where they produced an intramedullary pressure with a cement injection. And then also, kind of like the echo study, looked at the volume of emboli that made it into the pulmonary space on autopsy, and they definitely documented a statistically significant change between filter and no filter. I think this is interesting only because we put a lot of IVC filters in today for other reasons. The problem with that is you have a lot of patients, only 10% are going to get the syndrome, and your filter comes with a thrombosis rate of 2% for a DVT in that leg. So I think it'd be hard-pressed for us to ever figure out the perfect patient to get these and to get them before their surgery. So outcome, what about outcome? So I told you a patient, I took care of it, and my fellowship died. So you would think I'm high-fiving myself in my office right now. I'm not. I'm going, well, great. I don't, this, he may have it, but he's, I have this G-SSF4T, it's alarming. So I try to figure out what the outcome is in regards to cerebral fat embolism syndrome. Because again, my last patient, it was profoundly the ARDS. He had a cerebral component. We weren't able to diagnose it at the time, but I really was unclear on what the outcome might be here. And this is coincidence number 3. An article published 2 days before Jay hits the hospital door. Online publication ahead of print. It would be published in November, I think, in the Journal of Neurosurgery. And this fellow was a neurosurgery resident who had taken care of a patient that sustained fat embolism syndrome after a humerus fracture, and then actually she had developed cerebral edema enough for them to do a craniectomy on her, which probed him to investigate what outcomes should be after that procedure. So he looked through 22 years of literature. He could only find 54 cases, not just of fat embolism syndrome, but where they kind of captured the initial coma scale and had far enough follow-up to document the final GCS and how the patients did long-term. And he had a nice chart of it on the second page of this manuscript. Again, it was the first thing that would come up on PubMed. And, you know, case reports, people dismiss them, but a lot of times they have the latest discussion on fat embolism syndrome. And I'm thankful today that I opened this paper and read it. And I've actually corresponded with this author. And I will show you, this is an unusual CT. They captured the fat emboli to the brain on this particular CT. If you would happen to catch it, this patient probably had a PFO and got some larger fat emboli to the brain. It's very, you know, looks black like fat does, low attenuation. And this actually has been described on CT of the chest now in a few cases where they're getting a CT to look for PE, that if they have these really low attenuating, maybe it's fat embolism syndrome. But Jay fell into this last category. He was in a severe coma, but he had a 60% of recovering completely with just a mild or disability or to be completely intact. That's a lot better than watershed strokes. So this made me convinced I definitely need to discuss this possibility with his family and let them know and let them decide. You know, the train was moving. The train was moving towards the comfort care. We were not escalating care. In fact, that day he needed blood and had a fever. His stump was infected. And we weren't doing anything. We weren't adding anything. And I will say I was a little intimidated about jumping in front of the train. And that's because I'm not a brain expert. I mean, I do what I can, but 2 neurologists have said these are watershed infarcts. But I did have my story, and I felt like he fit the criteria. And I really put myself in the family's position. This is a young, healthy guy. What would I do? The best thing in this case report was it actually documented that most of the recovery is in the first 4 to 6 weeks. It can take 2 to 3 months. But I might be wrong, and everybody else might be right. And then the family has to sit there and watch as days go by in the ICU, and we see this as critical care faculty. It's torture for these families. And so I will say I had mixed feelings about this. I knew what I would do. I mean, I thought I would, you know, was right. I'm passionate about patient care. But it was not the easiest of things, even for me to think how I would have this discussion, how I was going to walk in and say, guess what? You know, it wasn't like that. It was a very sobering moment for me and realizing I needed to talk to this family carefully, because when we wait 4 to 6 weeks to withdraw care, a lot of times that's removing fluids and nutrition. As opposed to if we extubate him at a GCS of 4, he's probably not going to do well from pulmonary status, get pneumonia, and pass away quicker. And sometimes for families, that difference is very different to them, withholding fluids. And I had to make sure, in accordance with Jay's wishes, that they understood that we may still be at the same point. It might just be later if they decided to do what I thought they should do. So I went up and I talked to Lisa, and Jay's mother had flown into town, and I actually gave them a copy of the paper. I mean, they may not be medical, but they can read into it, the case reports, and think about it with as much knowledge as I could. And I told them I'd be comfortable with whatever they decided. And so they were going to think about it overnight, and I would come back the next day to round on him. I wanted to show you these quotes from Dr. Stewart, who's written a chapter on palliative care medicine, and I think they're very pertinent to this case in general. You would think the longer we practice that we'd get more confident in our prognostication, but we actually get less confident. We see people survive who we don't think should, and we see others die abruptly that we didn't think would. And so really you have to always proceed with caution. And then the second quote really related more to Jay. His wishes were clear. He did not want to PEG. He did not want to be ventilator dependent. And really recognizing those and saying, you know, we may be doing the same thing, it just might be a little bit later in time, and realizing that at some point, if he didn't get better, you know, you have to acknowledge what he really wanted. This will be the fourth coincidence, last I'll talk about. So I own an old house in King William in San Antonio, built in the 1800s, and I'm always on the lookout for furniture. And I got a call from someone that they were going to have a private estate sale, and if I wanted to look at what was going on, I needed to go to this contemporary art site and scroll to the bottom to a link to look at pieces of furniture. And so I'd go do that because I was going to get me some good furniture. And I'd see this picture or this painting, and I wouldn't even really look at it the first time through. I'd scroll through and to the bottom, go look at the furniture. And then the next day I would come in and round at Jay and look at Jay. And it was moving to me in a way, the painting, how the subject has the same facial pattern, kind of the same color hair. He's looking through that glass bowl. There's nothing in the bowl. There's no fish there anymore. And maybe pondering what was, what will be. And I would come to look at this painting many times over the few weeks as the family decided to side with me and give Jay a little bit longer. And I had a third neurologist come see him, gave him papers on fat embolism, said, please tell me I'm not crazy and that this could be real. They also said they thought he had watershed infarcts and was going to not recover. And so I was kind of standing alone in front of the train with the family, but I also didn't want to be the one giving them false hope. That's even worse to me in ways to do that. So I would look at this painting many times throughout the next few weeks. He would go to the OR on the 10th day. They would decide to continue with aggressive care until things became evident. They would revise his stump for an infection. He would gain 1 point in his GCS on the 2nd. I was so excited that day. On the 7th, he was extubated, still with a poor GCS. The family, adamantly didn't want a trach and a peg. And Dr. Dent extubated him. I'll remember this. I had a conversation with him about, his GCS may not be perfect, but he's ready in other circumstances. So he got extubated. His GCS was improving. Started taking PO. This is Jay retrospectively tells me his favorite day, using profanity and laughing inappropriately. And I did get a call from Lisa that day about, what did she get back? And I said, oh no, it's good, it's good. The frontal part always comes back for whatever reason. We see that in the ICU, but she was a little alarmed on that day. He went to Rees on the 29th and to neuro rehab on the 1st of October. And it's a beautiful picture, Jay, contemplating his new existence with his stump down there, taken by Lisa with the light streaming through in Reeves. She took some beautiful photos during his journey. And I wouldn't, get to know Jay during all of that, but later, it's been my pleasure to care for him. We're obviously very close today. He's a great guy. He's had a great sense of humor. He pushed his rehab to the limit. And Jay rides again. He's a competitive cyclist with his prosthetic. He can buy sports prosthetics you buy on eBay, just for, it's kind of interesting to me that for different sports, you need different types of prosthetic. And Jay loved his unknown George name, and his competitive racing gear reflects that. He has a Facebook page. He helps other disabled athletes who are doing triathlons learn to cycle better, and he's an incredible human. And I think that's one of the other messages I want you to get is sometimes we're busy, we're walking through, but these are incredible people we have the pleasure to take care of. So in conclusion, occasionally there are zebras. Any trauma patient with a long bone fracture or pelvic fracture who is initially lucid, who subsequently develops mental status deterioration should get an immediate evaluation for fat embolism syndrome. And guess what? You need to go look at their armpits. It doesn't, we dismiss physical exam a lot of time for data, but if you see that, you're almost sure that's what it is. You're gonna do other things, but it's critical, and that's critical in the early time frame. And then the MRI, again, that Starfield pattern, while it can reflect other diseases as well, in the right clinical scenario, it's pathognomonic for fat embolism syndrome. I want to thank you for your attention. I hope you'll remember the story. I hope you'll have the pleasure of making a zebra diagnosis in your career. It's been one of the most rewarding things I've ever done. It had nothing to do with doing a surgery. I feel blessed to have been a part of this journey. I also want to give a shout out to Rachel Garvin. I, again, was feeling very alone in front of the train. So she's a neurointensivist, and I asked her to take a look at the case and tell me, did she think I was crazy, or did she think I had something? And she was the only one who stood with me and really would help me throughout Jay's care and course throughout his hospital stay. I'll be happy to take any questions.
Set the bar very high for any.
I just want to know, are you okay, Dr. Pastana?
Dr. Pastana.
Question, please. Obviously, your message is because this is a better problem in the brain than the standard stroke, don't rush to withdraw care from the patient. But you don't want, on the other hand, to give too much hope to a family. Can you repeat for me how many of the people with a fat embolism to the brain actually die in spite of the fact that it's not as bad as a standard stroke?
Well, out of all the people who get fat embolism syndrome, so not just the fat emboli, but they've developed this syndrome, the mortality in that group is 10%. And there's definitely mild, kind of moderate, and fulminant presentations of it. And again, the patient from my fellowship had both severe cerebral and ARDS, and obviously the brain does very poorly with the hypoxia if you have ARDS. So again, looking at the cases, there may not be as many like Jay, who for whatever reason the cerebral component dominated his respiratory component, but the mortality in FES is 10%. So 90% of them will survive. And most, about 60% of those cases would be expected, even with severe coma, to have a good neurologic outcome, which is really the most important. You want quality of life.
Dr. Dan? So, Deb, great talk. A couple of questions. One, I've always thought with head trauma, which is the more common thing we see, you don't write them off unless something shows you dead brain. You know, the CT scans that show more swelling or a little more blood, or in this case, the findings that were shown on this MRI, to me, don't say this person isn't going to wake up. Now, sometimes we see, you know, an infarct area, and then you can tell the family this person's going to probably not be able to use their left side, or, you know, maybe a speech area if you get the neurosurgeons involved, that sort of thing. So, is this any different than that? I mean, those watershed areas, to me, didn't really strike me as, you know, large area of dead brain, if you will. And so is that, I guess, one of the take-home messages here?
Yes, and I actually have given a lot of thought since this case is we probably have patients who have both. They have brain injury and fat embolism syndrome, and sometimes we're always gearing on that GCS every day, but do we know which is which part of it and which may recover? So I think, again, with time, that prognosticating fact is true. We've, especially the younger you are, the better brain recovery you tend to have. But many of those patients, we suggest a trach and a peg as well, and the family at that branch point sometimes is considering continued care or not. We want to get those done early so they can progress along their care. So I do think it's difficult, but I've certainly learned throughout my degree to be more patient. And if I'm not convinced, again, a big infarct, brainstem infarcts that we occasionally see, to definitely not be the person pushing what goes forward. And it does take the brain a while to recover from any trauma. But I think we get caught in that situation sometimes only because the trach and the peg really sound like, we're going down the nursing home route no matter what, which isn't really true. You can withdraw care at any time, and that I think is another important message.
So, yeah, I mean, that reminds me of a story. Intern year in urology clinic, seeing a guy who came in for his erectile dysfunction drugs, and the name looked familiar to me, and so I looked back through his chart, and it was a guy who I'd cared for in our VA ICU for a long time, with a perf ulcer. Nothing wrong with his brain in terms of trauma, stroke, anything like that, but the brain is just another organ that goes into dysfunction when you get sick, just like lungs do and kidneys do and livers do. And he told me, yeah, I remember I was sick on Christmas Eve and came to the hospital, and next thing I knew it was April.
Yep.
Okay, because he was that sick. I mean, he was, respiratory, renal failure, multi-organ system sick. And now here he is in June looking for his erectile dysfunction meds. And so brains just shut down sometimes. And so I've never really cared too much about the GCS. Your other comment led me to my second question, which is, you've seen two remarkable cases that you recall and know of, but do you wonder, because you made me wonder, how many cases have I missed in my life? And,
Well, now I'm picking up a lot more because, of course, if I'm rounding in the ICU, I'm like, let's look at their armpits if they've just had. And actually, Juan Marcano and I one day went in, and sure enough, petechiae, I was told the guy, they weren't sure why he was, having respiratory distress. So I think if you look, you'll realize it's there a lot more than, but again, not in its fulminant form. But physical exam is what you have to do. Remember, 40% won't have that, but I think it's there. I think it's just, we can't treat it. So do we worry as much about diagnosing it as other things? It's supportive care. It's what we're doing. So that may lead us not to really make the diagnosis that often, even when it's there.
Did he have anything in writing as far as directives, or was this word of mouth from
Well, you know, none of our comfort care situations are ever straightforward. So he gave medical power of attorney to his girlfriend when he was in the trauma bay. The mother flew in from out of state. It was fun, walking the line between those two when decisions were made. But he had made his, I mean, they both agreed with what his wishes would be. I don't remember him having an advance directive, but it was more verbal of what he would want. But again, it made it interesting from other standpoints. The mother was less convinced than the girlfriend that he could have fat embolized syndrome. I think she was kind of ready to accept and had been told, you know, by several brain specialists that he would not recover. So she was a little more reluctant.
Especially with 3 neurologists. Dr. Pounds.
My question is, for the 3 neurologists, has there been a sort of...
Oh, yeah. Jay and I went to his clinic appointment together. And I'm joking about it now, but I'm passionate about it because I feel like he's not the only one, you know, they're out there. And I really, Dr. Birnbaum was the third one who saw him after I suggested it. And we had a nice visitation. We talked to the fellows. I've spent some time educating them about the possibility. And also I've given this grand rounds to orthopedics. I mean, it's their patients, and none of them had thought of it either. The orthopedic residents or faculty, and they're the ones who are going to probably see it even more unless you're critical care attending. So trying to spread the word. Again, you won't see it a lot, but because the outcome is so different, I feel, you know, it's very important that we remember the zebras.
Dr. Pounds.
I was just going to say, you know, we have the palliative care train, and, you know, I believe in a lot of this, but it's also become very much a paintbrush for everybody. It's kind of like come in and day 2 or 3, like, oh, yeah, boom, check, out. So I really, really think it's amazing that you know, this happened, that you're able to save this guy and sort of persevere and stand up against the crowd, so.
Well, I want to say that that's one of the other messages. We get busy and we're rounding and we're trying to get through all the patients in the ICU and really stopping just to make sure. I talked to the faculty who rounded the day before me, and he said, you know, I didn't give it a second thought. They said he was going to be going to comfort care, and I didn't give it a second thought. And I think it's a reminder to us. We are in a powerful position. We need to use it wisely. And really, it's not hard. Does it make sense? Does the story make sense? We'll talk about this often in Trauma Morning Report, is if it doesn't make sense, you got to dig down another hole, find another path. So if something's not making sense to you, dig a little deeper. You may not know what it is right then. I happen to have that old story, but you can dig, and sometimes you'll find something.
So we have a lot of consultants, including palliative care. I think the problem is that it's difficult to practice team medicine, and we still have to be the primary moving. We recently had a patient who came in with metastatic liver cancer, and there were just too many people, surgical oncology, medical oncology, palliative care, and us. And the patient and her husband were totally confused. And I realized at that time the problem was that we had to stay the #1 person guiding the course for them.
Yeah.
It's not that we don't want the palliative care people, but the patients get confused when they're getting information from 4 different services.
The painting hangs in my office above my desk. It reminds me on a day that I'm not in a good mood at work, that's why we come. Thank you.
Thank you very much.